I thought I had an onerous task this morning, introducing you and sort of discussing the logistics with you, but actually I've got a much more onerous task now of introducing the project director of HCP, Rimon, who's going to give us some remarks. I just want to say a little bit about Oying. I remember when I first arrived in Baltimore about 5 years ago, I wasn't quite sure about Oying. I didn't quite get him. You know what I mean? It took me a little while. You know what I mean? And, he sometimes has this rather gruff face when he's in meetings. But in actual fact, what I've learned, and I think all of us who've been working with Oying, is that actually one thing that perhaps not everybody knows, he's got the most sweetest heart. And he's one of the kindest people I've ever met. And that was really, when I first came, anyway, I won't talk about that, but he was an immensely kind person. And I think as a project leader, what I think we've all appreciated as the partners is how he's been deeply respectful of all the different partners, both in terms of the core partners of HCP, but also the partners all around the world. He's just so passionate about what he does and what the Center for Communication program does, and what we've been able to achieve under the Health Communication Partnership. I think Oying has led the field of communication for the last 20 years, and I think so much has been achieved under his leadership. And to be honest, he's also quite a humble guy. And I don't think that we all know and appreciate just what he's been able to do in terms of, not only in terms of guide projects, but mentor individuals and mentor people across the globe. So, I want to say from the depth of my heart, thank you, Oying. I can't see where you are. You're just there. You know what I mean? You've been the best of bosses, and this is the end of HCP, and we are really looking forward to hearing what you have to say. So thank you. Can you please welcome Oying Rimon?
Thank you, John. I may need to call Alvaro, your president in London, to make sure you get a big raise. When I was requested to do this over lunchtime, I said, I'm the dessert for lunchtime. I'll promise one thing, though, before I start, that I'm not going to do a Rudy Giuliani on you. So if my phone rings, I don't know if you know all this joke, but if my phone rings, I'm not going to answer it. John or somebody billed my talk this morning as controversial. Well, actually it was. Until I rehearsed with a number of colleagues, and then they said, you can't say that. No, you can't say that. Come on, Oying, you can't say that. And I'm not sure whether it's controversial anymore. So we'll see. All I can say is that if you agree with some of the ideas and the assertions I'm going to present to you, then consider that the collective judgment of HCP. If you disagree, then you could blame it on me. And I'm willing to take that. So let's start. At first, it was 6 big ideas, became 7 big ideas, became 9 big ideas, it became 30 big ideas, and finally it became 10 big ideas. First, the more communication, the better the impact. For many of us who have worked in this field, you always hear this complaint. Oh, we don't need to do communication this month or this year because we did it last year. So it's not necessary anymore. But if you say that in service, we're not going to provide service this year because we provided service last year, that's a no-no. But in communication, it's a yes, sometimes. Multiple communication interventions have cumulative and reinforcing effects, as I will show you in the next few slides. Communication has dose response effects, multiple media effects, multiple program effects, and complementary messages. Let me illustrate the case of research done in South Africa in one of the programs supported by HCP. And here, the question was, on the part of the government, when HCP decided to evaluate its own program, the government said, why only your program? Why not evaluate all the 18 and 19 other communication programs in place in the country today? And we'll see whether, in fact, the more communication, the better. And we said, wow, that's really tough. That has never been done, as far as we know, anywhere in the world. Then I'll tell you later on what they asked next time around, which was also impossible. And the third time around, it was also very difficult. But we said, okay, we will try. And in this particular case, it's 18 communication programs together have substantial impact on HIV prevention and people living with AIDS and HIV. Take a look at this in terms of condom use in South Africa. If we don't control or adjust for 19 socioeconomic variables, this would be the effect. Here, 18 programs, you would have a 51-point spread. So the more you are exposed to 18 programs, the more likely you're using a condom. But that's not controlling for 19 socioeconomic variables. Let's see. If we control for this 19 socioeconomic variables, would a 51-point spread would still be there? And the answer is, here it is. It is still significant, 19-point spread, the same data, percent of condom use. And we can go on. In the case of HIV test, 25-point spread. This is already controlling for the 19 socioeconomic variables. So the more people are exposed, the more likely these behaviors occur. In the case of percent of people, this is related to stigma, who help care for a person sick with AIDS. Again here, 16-point spread. Related to this is big idea number 2. If we are going to advance this field, we have to measure with precision. Otherwise, we will never gain that credibility. So, my subpoints here, contributions of individual communication intervention can, in fact, be disaggregated and measured. Again, this was the request of the South African government in this particular case. They would say, evaluate the impact of 19 communication programs, and by the way, could you attribute the contribution of each and every one of them? It's never been done anywhere in the world, as far as I know. I've been in this business for more than 30 years. But here, through the use of many different kinds of techniques, and I think many of them have been discussed this morning and will be discussed this afternoon, and I am not the expert on many of these methodologies, so I would not dare explain them. Otherwise, I'll be killed by our researchers here. Can we disaggregate the impact of the health communication supported program in South Africa using the Chat television drama from the effects of all the 18 other programs? And here is the result. Unadjusted for those 19 relevant socioeconomic variables, unadjusted for the propensity scoring analysis, which even makes it more tighter and more precise, then in fact you could say that there was a 23% additional users of condoms as a result of just exposure to the Cha-Cha program, controlling for all those other variables, and controlling for all the other 17 interventions. But, again, if you use this more precise measurement, with the use of propensity scoring, this 23% goes down to 7%. Still significant. And I will go back to that 7% later on. 3, go to scale now if you want to achieve cost effectiveness. Cost effectiveness of reach and impact of communication interventions can in fact be measured. I remember, having been in this business for a long time, 25 years ago, this was the preoccupation at the World Bank. I was part of that team. Finding a way whether in fact you can measure cost effectiveness at scale. And the bank gave up. Couldn't be done. Couldn't be done. But 25 years later, I think we can say it can be done. In many different ways. By many different organizations. If we know what to do, we can skip small-scale trials and implement at full scale to achieve population-based impact at lower unit costs. And to me, this is also an ethical issue. If we're dealing with people dying of HIV/AIDS, for us to experiment with one small thing here and there is unethical. We've got to go at scale because people are dying. So let's take a look at some of this cost effectiveness using the same project to make it simple. That cha-cha intervention, for every additional condom user, it's about $3.13. About 16 cents to reach per person. Is there anything you can take a look at that? 16 to reach $3 for additional condom user. Well, that's not only cost effective, but if you analyze that, it means that for every 19.5 persons reached through cha-cha, one becomes a condom user. And think about the fact that you are not really targeting this to those people who can just use condoms. So the conversion rate is quite high if you have 1 out of 19.5 persons become a condom user. Now, that's just one measure, condom use, for the same amount of money. The same investment, same amount of money, help to simultaneously influence behaviors not only in condom, but on a range of other behaviors, from HIV testing to stigma. Same unit cost. If you add all the other multiple behaviors that could have been affected by one program, not just in condom use, but stigma reduction, HIV testing, then just think. You can multiply in your mind the cost effectiveness of a prevention program like this. And I'm not sure whether Larry Kincaid's presentation was presented this morning or in the afternoon. I think if you look at it in terms of overall program, again, this paradigm between prevention and curative, if a prevention program works, as in the case in the data I presented, you can save up to $5.8 billion, on curative ART in one country alone like South Africa. Just to show you, from Africa to Asia, this is a 3-phased program in the Philippines, and we took a look at the cost effectiveness of that also, using the most advanced and stringent measurement. Here, in terms of per person reach family planning, that's 6 cents, 157. For radio alone, it's expensive, more expensive than TV. Okay. But if you take a look at this, the numbers are more or less in the vicinity, whether you are in Africa or maybe you are in Asia. To reach, maybe between 6 to 16 cents. For behaviors, maybe from $1 or $2 to $3. And I was told by other people in this business, the entertainment education people who does this summit every year, they said they have more or less the same figures in their own research. Mass media, because they operate at scale, reach and influence more people, can be most effective. And people are saying, oh, Ying, you know, your mass media bias is showing all over again. Well, it may be a bias, but I'm just looking at the data. I'm not saying that just use mass media if you want scale and you have population level impact. Because we know that if you use mass media in combination with maybe community or interpersonal communication, you'll be more effective. But it depends again on what you're trying to achieve. And since that time, 25 years ago, and it was the World Bank, with all the brilliant economists there, gave up in terms of doing cost-effectiveness analysis of communication impacts. Finally, you have a special issue on health communication, groundbreaking special issue on cost-effectiveness published in 2006. This is the first of its kind that I know of anywhere, this special issue. And this is going to influence the next generation of thinkers, scholars, practitioners in the area of health communication. 4, for sustainable impact, change social norms. Not that controversial, maybe. Maybe it was controversial many years ago, but not anymore now. But my interest in this, and I have this interest for a long time, is are there tipping points in terms of sustaining behavior? And we believe there is. But we just didn't have the data until finally we were able to look at certain data. And just take a look at this. I think this was presented by Doug Story this morning. In Indonesia, which I'm very familiar with, in 1997, that was the worst economic political crisis the country ever had. The worst. At the time, since I used to go to this country a lot, I was told by every single official, every single donor, that the program will collapse. The family planning program will collapse. The budget is not there. The contraceptives are not there. This is going to be a critical juncture in the history of family planning, and it will collapse. In fact, I remember that I was one of the very few. I said, no, it's not going to collapse. In fact, it's going to survive and thrive. And USAID sent me a top journalist from a German magazine because I was the only person saying the opposite thing. And I convinced the journalist that if you write a story, if you just say it's going to collapse, it's the same old story, economic crisis, collapse. But I said in this case, you have a good story because it will not collapse. And in fact, he made a good story about that. So here, in the case of Indonesia, 1997, the worst economic crisis, everybody said the program will collapse. It went up, the contraceptive prevalence. Why? Because there was internalization of demand and the social norms supporting small family size have become a norm in many of those communities. And let's take a look at this data that was, I'm repeating this data that was presented this morning because the other half of the group did not see this. In Indonesia, when we look at cluster analysis of districts, kabupatens, where there is minority support for families, small family size, meaning less than 50% of the people in those districts believe or have internalized the concept of small, happy family size, dua anak cukup, 2 child enough. Here, in districts where you have high initial CPR, it actually went down by 10 percentage points. But because they are low here, most probably they have nowhere to go up but up. So it went down. But look at this. With high initial CPR, where the social norm is in place, more than 50% internalize the value of small, happy family size, didn't go down. It stayed, and in fact, it went up in the low CPR area. And that explains this. 5, use communication to transcend physical, economic, and cultural gaps. Again, sometimes when you have projects, we always think, what geography? Is it this province, this district, There's always something there, geographic barrier. communication networks, not physical boundaries or proximity, influence behavior. The power of ideas spreading through language, through cultures, and people of similar interests, by the way, has been proven by the adjacent studies by Cleland and Wilson when they studied the demographic transition in Europe. It was not the socioeconomic level, it was not the geography, it was this. The idea that people can control their family size, that was a radical idea at that point in time. But it was such a powerful idea that it spread through language, cultures, and people of similar interests. Internet, mobile phones, mass media cuts across all those geographic boundaries. We know, for all of us who travel around the world, the number one soap in Ukraine is what? It's a Venezuelan soap. Sometimes it's a Brazilian soap. You go to many parts of Africa, what are the most popular movies there? It's the Bollywood movies which dominate. No? I just came back from a vacation in the Philippines 3 weeks ago. The number one soap in the Philippines is a Korean soap. Communication is not bounded by geographic, You can think, you can imagine, and you can reach. Think scale. Think what you can do with internet. Think what you can do with cell phones. 6, institutions are best built through collaborative learning, not training by experts. In the context of globalization, self-sustaining institutions are interdependent and connected with larger networks through collaborative learning. This was one idea that I kind of edited a little bit so it did not sound too controversial. But in fact, what I'm trying to say here is that we need to transcend the old paradigm that the more independent an organization is, the more it does not need to engage with donors, the more, it's not connected because it's supposed to be strong and independent. It can survive on its own. I was about to say something bad, but it's not the right thing, in my experience. These are institutions which are interdependent and connected with other institutions, who know how to deal with donors on their own terms. These are the institutions which have collaborative learning on their side. It's time for us to get away from that old paradigm of thinking in terms of capacity building. Measure both direct and indirect effects of communication. Measuring only direct effects systematically underestimates program reach and impact. And we have done this over and over again, even now. We continually underestimate ourselves, shortchange ourselves, because when we evaluate our programs, we only evaluate those who are directly exposed to our programs. I'll show you some data here from Nepal just to illustrate this point. This is a village in Nepal. The blue circle are women who have recalled the radio communication program. And the squares, they were not exposed. But for every person, blue, who were exposed, there was some other person who was indirectly exposed. Either they came to the person who was exposed, or the person talked to them, but they were not directly exposed. Okay? But look at this. The level of behavior change in this, at least in this particular study in Nepal, among those directly exposed is about the same level as those indirectly exposed. In fact, numerically higher, but not statistically significantly higher. Just look at this. We have been underestimating the reach and the impact of communication all these years, simply if we look at those who have direct exposure. And we have done that. All of us are culprits in terms of that. And just look at the implications in terms of cost effectiveness if we begin looking systematically at this indirect exposure to our programs. 8, the impact of health communication and behavior can be predicted. Many of you perhaps will disagree with me on this, so just say that it's Oying's crazy idea. Okay. Health behaviors can be predicted using probabilistic models. One of them is ideation theory. Ideation model, in the case of HCP and CCP, have been applied in 15 countries around the world in the areas of family planning, HIV aid, water treatment, avian influenza, democracy, and governance behaviors. And we have seen a consistency. Yes, behaviors can be predicted if you know how to do it. And let me just show you here. I think I have 2 examples here. No, first, just to show you, these are the ideational factors that you could take a look at. So it's a predictive model of communication in chains. Okay? It implies simultaneous effects of all the influences, not just one. Okay? So in the case of Zambia, in terms of factors on condom use, young female condom use, these are the ideational factors which came out. And this is how it predicts. If you have the 6 factors here, we will predict 61% of the time you're a young female condom user. In the case of Zambia, it could be different in another country. Okay? Took this from a study on Philippines and contraceptive practice, the same stair-step model. If you have 10 of those factors, and I didn't have time, to list those factors here, 80% of the time we will say you're a modern method contraceptive user. We will predict you are if you have those 10 factors. Now you say, he's crazy. But think about it. Me, I had stents done 2 years ago here, right here in my heart. But then I say, okay, if you don't exercise, if you don't eat good food, okay, if you don't exercise, you don't eat the right food, if you have family history, it's most likely you will have heart problems. There's nothing that's not different from that. It's only the application of the same idea if we just be innovative and creative about it. 9. I think Gloria Ko will love this one. Communication can influence gender equity as a gateway to multiple health behaviors. Think about this. Okay? And we have emerging and growing data from the evaluation of Africa transformations in some of the formative research done in Ethiopia. That in fact, if you deal with gender equity, you have a very good chance, at addressing other multiple health behaviors. It can become a gateway behavior. I think this is still a work in progress in terms of really understanding the dynamics of this, but there's something here that can be really revolutionary if we take a little bit more innovation in thinking about this. Finally, learning does not stop when the program ends. Learning does not stop when HCP ends. Many of these insights that I'm sharing with you were not driven simply when you do program impact. Because you do this all the time to satisfy your donors, you do an impact study and then you say, this is the impact. But we sometimes don't have the luxury to say, can we do a secondary analysis? Can we do more data mining to really gain insights? And I would hand it to AID, that AID allowed HCP to use core money in order to do this data mining, in order to do this secondary analysis so that we can gain insight, rather than just continually reporting on what's the program impact. 100 scholarly articles written under HCP. Just imagine, 100, and this is not even an operations research project. And that 100 articles will influence the future generation of how communication is taught, how it is going to be practiced. Sometimes programs do that too. But 10, 15 years from now, who will remember programs? Very few of us will remember programs. But they will remember the students, the scholars, the practitioners, those articles that were written in scholarly journals. Can you believe this? What F. Rogers and Wilbur Schramm wrote 30 years ago, that mass media don't change behavior, is still being taught in communication schools all over the world right now. And many of us still believe that mass media don't change behavior. Well, 30 years ago, when they wrote that, there was even no TV. It was radio. And yet we keep repeating this thing, So the legacy to the next generation of health communication scholars and practitioners, whether we like it or not, we don't want to play this game, but they have to get into the scholarly journals because that's the way the world works at this point in time. So thank you very much. And I would like to thank all my friends and colleagues who work on this project and continue to work and advance health communication and save lives.